Welcome to Talking Science Africa, a show where we host researchers and innovators in the science space to explain to us the work that they are doing and how that work is relevant to our life. Today we are excited to host Dr. Flavia Matovu Kiweewa. She is the research director at Makerere University, Johns Hopkins University Research Collaboration. But also she's the national investigator, she's the national principal investigator of the Lenacapavir, which was rolled out recently in Uganda. It's this exciting 2-year injection prep that you have for hurdle, and here she is. She's going to tell us what it's about and much more. Doctor, welcome to the show.
Thank you so much, Blush.
It's a pleasure hosting you.
Thank you.
For me, much of the time when I'm interviewing researchers, the first question that I ask them is, how did they end up researching on the areas they research about? You research on the disease, which has been one of the most traumatizing diseases of the past 40 plus decades. And how did you end up focusing your time, your energy on research about HIV?
Yeah, well, thank you so much. So, like many of us who lived in the 80s and 90s, and saw how the HIV pandemic wiped out many people, how it affected families, not just neighbors, not just Uganda in general, but our own families. I was drawn to the field of HIV, like you say, to focus my energy to see how I can make an impact. So I come from a family of 9. My mother had 9 children. I come last. I'm the last born. In 1990, we lost our brother, the firstborn. By then we didn't know it was HIV. But later on, when his wife died and 2 children, and we looked after them after they had died, we knew that this is now HIV. And then in 1991, it was less than a year, my sister dies. 1994, another brother dies. 1996, my follower was diagnosed with HIV. It was in his early 20s. Diagnosed with HIV, and then in 2001, he passed on. Remember, in medical school, he used to come to look for, but by then there were no ARVs, but he would come for treatments. He would have oral sores, TB. And I remember he spent a lot of time looking for doctors to support him. When in 2000, he passed on. So, yeah, so because of that, when I finished medical school in 2002, then I decided to join Rakai. He had advertised. I knew about Rakai because I had been doing a lot of work in HIV, and I had done my internship in Masaka, so it was close by, and it was easy for me to get in. So I was drawn to the advert. They interviewed me. I was able to go through, and the first study I worked on was again a study looking at natural history of HIV. It was called the Molecular Epidemiological Research Study, or MARE. So in that study, they would get participants who seroconvert from year cohort, because they have cohorts that they follow up since, I think, 1986. I've been following them up for years. So those who seroconvert were put into a study, a sub-study that is nested with the main cohort, whereby they would follow them up to see how the HIV evolves. So from the time someone is diagnosed to the time many of them, of course, would die. Because that was 2002, 2003, and early 2004 when I left Rakai to come to Muju. So I saw someone changing face from a healthy person until fully blown HIV, and later on, of course, many of them died preceding his till 2004-5 when the ARVs were available. So all my life, it's been about HIV, it's been about people are here to be tomorrow, they are not there, looking after orphans. Yeah.
There is that sad story that many people speak about. Also, the exciting part of at one time HIV was a death sentence.
Yeah.
And now it's no longer a death sentence because of the advancement in such, the advancement in the development of drugs and the prey. Everything else that many people, including me, have been part of. So let's quickly turn to Lenacapavir. What's Lenacapavir and where did this idea originate from?
Lenacapavir is a drug that's already approved for HIV treatment, because for a drug to be used for prevention or prophylaxis, it has to be able to treat that disease. For example, if you look at malaria prophylaxis, we use the real anti-malarials that would have cured someone with malaria, but this time you give them to someone to take them before they get the malaria, because before they get exposed to malaria, so that by the time a mosquito bites them, they have enough drug in their system, and then they cannot get the infection. So the same concept for PrEP, for Lenacapavir, is already treatment for HIV. And then in 2022, it was approved for those who are highly treatment experienced, meaning that someone has failed on all regimens, first line, second line, third line, nothing else can work on them. Their HIV is resistant to all medications. And then you are able to take that drug and it suppresses very low, though they combine it with some other pills called Vitavik. So the manufacturer Gilead Sciences decided to turn it to a preventive agent. So if it can be able to suppress HIV that is resistant to all other medications, how about preventing someone who is not yet exposed? So we conducted this study, the Purpose 1 and Purpose 2. There were two studies done in parallel. Purpose 1 was in adolescent girls and young women in Uganda and South Africa, for the burden is highest in young girls. And then Purpose 2 was in male sex with men, transgender men, and gender non-binary individuals in the Western world, US, Brazil, South Africa, and both studying consistently showed that this drug is very effective, almost 100% efficacy against HIV. So Lenacapavir is already a drug for treatment, but changing it to prevention, because it is highly important. It has a unique mechanism of action compared to other drugs that work or attack the virus at one stage. Lenacapavir attacks the drug at multiple stages in the HIV life cycle. So it alters the share or a capsid of HIV and distorts it, and therefore the HIV becomes multiply. And the other unique aspect of Lenacapavir is other ARVs, they work in defense mechanism. The virus is here, then they act against it. Lenacapavir sees the virus coming and attacks it before the virus attacks it. So that makes it very potent. And then it has a very long half-life of 6 months.
What feeling did you get as the national principal investigator when, after these trials were conducted and the results found out that it was highly effective?
Yes, so I have worked on so many trials. Like I said, I joined Moju way back almost over 20 years now. And I've worked on almost all the HIV PrEP trials in Moju, and I could say in Africa. Because we first worked on a trial that was looking at the pharmacokinetics of the oral PrEP we have now. It's called MTN 001. And then after we were able to ascertain that the oral PrEP, the Truvada tenofovir now is safe, then and also looking at the drug levels, the pharmacokinetics under the microbicide trials network, we were able to do another study called the VOICE study, where we are now at phase 3. Phase 3, we are looking at whether the drug works, as much as we also continue to study whether it is safe. So in this phase 3 trial, unfortunately, because we had women who are on placebo, the drug that has nothing in it, that looks like the actual drug, and then we had the drug that is actual, the Truvada. There's also a gel in it. But at the end of the study, we saw over 350 infections, and they were randomly distributed between the different groups. That means that the drug did not work. But not knowing that the women had not actually adhered to that drug. So by that time, now we know better in all the trials. We test for drug level that you go on a real time to know whether women are taking or not. But for that trial, we kept the samples until the end of the study, and then they were shipped. And then at first women take, and then later on, because of misconceptions and fatigue, they stopped taking, and therefore were not able to prove that Truvada works. Good enough. Partners PrEP, and there's another study in the US called IPREX that was done to look at the same drugs, and they showed that Truvada works to prevent HIV. So in Voice were disappointed. Then we did the Aspire study. I was PI on the Aspire study that looked at productive urine ring, and it showed moderate efficacy. But now when we look at Lenacapavir giving us by interim analysis, it was 100% efficacy, though later on there were 2 infections. So it was really, it changed the history of PrEP. It was a moment in history which we had never seen, never imagined that we could have an intervention that works 100%. And it is really exciting. No wonder some people are calling it the miracle drug, the game changer. It's the closest to a vaccine, though it's not a vaccine. It's important to note. So we are excited that Lenacapavir is going to change the trajectory of the HIV, and the landscape will significantly change, and we'll be able to see almost zero infections, new infections in the next few years if it's widely rolled out.
Yeah. I know there are always, for you people involved in clinical trials, there are always those disappointing moments.
Yeah.
And development.
It was disappointment of disappointment, yeah. One after the other, yeah.
That many people never come to know. So, how important...
And to take you back about Lenacapavir, it started in the laboratory over 2 years ago at Gilead Sciences. So, over 20 years, they kept on looking at this molecule and then modifying it, changing it, until finally they came up with a final product, which initially was tested in the laboratories, and then you move on to the phase 1 studies, in the treatment trial, and then finally the HIV prevention trial. So the victory you're seeing today have not started today or 2 years ago, 3 years ago when we began the study. It started over 20 years ago, which is the sign of resilience and also willingness for our global collaborators, Gilead Sciences, to invest in a product that can be able to reduce HIV infections.
How important is Lenacapavir in the fight against HIV/AIDS? People are excited about it. In that context, how important it is?
So Lenacapavir is very important in the fight against HIV. First of all, because it's a twice-yearly injection. So even someone who is not able to take oral PrEP or return to a facility, because we have other interventions, other injectables like for 2 months, like cabotegravir. Someone who may not be able to make it every 2 months, at least to spare 2 days in a year, and you say, I'll get this twice-yearly injection and be able to protect myself. And also the confidence to know that it's almost 100% effective is reassuring, and knowing that I'm protected when I use Lenacapavir. So it's going to be a game changer. The only limiting factor, which the manufacturer Gilead Sciences already has a plan for it, is access. Access may be the limiting factor, but already with an access plan by the manufacturer, even before the Food and Drug Administration licensed Lenacapavir for PrEP, they were able to come up with a plan. First, they signed licensing agreements with the generic manufacturers who are at it currently. There are 6 generic manufacturers, including one in Egypt. And they are looking at, they are making a generic version that will cost only about $40 per year. You know that brand drug is about $28,000. This is going to cost about only $40 a year. So the other access plan that has already yielded results, or we launched Lenacapavir in Uganda. That's Friday, 17th of April. So Lenacapavir, the brand drug we have now is the drug we have now is a brand drug provided through Global Fund that was able to purchase this drug for resource limited settings, 18 countries, including Uganda. So they gave Uganda about $1.14 million to purchase that drug. So the subsidy, that being able to subsidize a drug from 28,000 US dollars over 100 millions to 80 to 100 dollars, that's about 300,000, is a big contribution by the manufacturer to ensure that we have access to these brand drugs, and they have commitment even before the generic versions come out, like next year and next year, we should be able to have the brand drugs available to countries like Uganda. So the US government is also coming in, and other donors hopefully will come in, and they'll be able to have Lenacapavir available without any shortage in supply. So with access to this drug, if we have so many people get that drug, let me say if you got this drug and you had more than one partner, if you're protected, your partner will not get the infection, even if they do not get the drug. So if you look at people who are at risk and those who are at risk of spreading to others, then we'll be able to terminate that network, that cycle of HIV. So what we're aiming at is having as many people access that drug, and therefore have the drug create impact by reducing the number of new infections in the country, but also globally.
If you put out a poster somewhere, who wants Lenacapavir? I think everyone can. So who is as per now, who is eligible to get it?
It reminded me about last week when we were in Lira for the launch. There were 40 doses that were availed at the launch, but they disappeared within like 30 minutes. People had completed, the drug was finished, and many more wanted to have the drug. So if we put out a signpost there, but you have this twice-yearly injection, if you're at risk, please come for it. Many people, even someone you don't think is at risk, they know their secrets. Many are calling and asking for that drug. Very important people, I'll not say the categories, but people who are, whom we think may be stable, they're all calling and asking for that drug. But we know those who are at obvious risk. We know that adults and girls and young women are at risk because of socioeconomic factors. They don't have money, they need to make a living. Many of them are disadvantaged. They are working in bars, they are working in hotels, they are working in farmlands. They are put at risk by the kind of work they do with sales sex. Many are in discordant relationships. We have truck drivers. We have people, and you know that your partner has multiple other women or other men, and you are at risk of HIV. So pregnant women, breastfeeding women, biologically they are at higher risk of HIV. So these are the categories that are obvious, and you'll access Lenacapavir, but we're not turning out anyone. If you feel you're at risk, you can go and you're assessed, and you can get Lenacapavir, because you cannot know what goes on in people's lives. And many people indeed want that drug, even those whom they think are empowered enough to protect themselves from having HIV. They also want that drug. They're asking for it.
I think I should also go and try for this doctor that I need.
If you need it, if you need it, we don't want anyone to get infected. If you need it, you can get that drug.
So after Lira, after last week's launch, where else is it available?
Oh, it's a long list of facilities. So Lira is one of the facilities. We are about 103 facilities. There is Maki, Mulago here. The nearest is Maki Mulago, just our neighbor here. And then we have Mukono, Mitiana facilities within. We have Mobende, Mbara, different facilities. It's a long list. I have the list on my computer, but I'm sure that if we're in an area, they'll be able to let them know where they can get that drug from. And the ministry should also be able to publish in the papers and let people know. But there are many, many facilities. So if you know of someone, maybe within Mukono, Then at Mukono Hospital, they can be able to give them Lenacapavir or direct them to where it is. Ginger, many of the big hospitals have the drug, but plus smaller health center force, they should have the drug. And by the end of the year, we are targeting about 300 facilities. We should have as many facilities have the drug, and someone should be able to access it without having to move long distances. But Kampala, you can get it from here, Mapi, Mulago, etc.
Then I think the first batch Uganda got 19,000 doses.
Yeah, 19,200.
If you ask people, they can, as you said, they can take them in one day. You say everyone can. They can take them in one day. So when is Uganda, how long will these doses last, and when will Uganda receive the next batch?
So the computation by ministry, these doses should take us up to the end of the year. But like you say, because the demand is so high, we may not be able to have enough drug by the end of the year. But already the people who are supporting us, like the Global Fund, US government, they are ensuring that we have enough supply before the drug runs out. So depending on how fast these drugs are consumed, was reported the same to the ministry, either weekly or monthly, and then we'll be able to know how much is being consumed and then how to plan for the next doses. But already the next shipment should be arriving in some time. Yeah.
You know, doctor, if I tell you one secret about myself is that I hate injections. And recently one doctor said they should give me an injection, and I was not happy. I think it was the first injection that I had gotten in 20 years. So many people fear injection. Why is this drug? Why does it come as an injection? Why not a tablet?
Yeah, so a tablet may not be able to work for 6 months. But an injection, because the way this drug works is that they inject you in the cutaneous fat. You have a skin, and then you have some fat, and then you have some muscle, and then you have the bones and the organs inside it. So we inject just in the cutaneous fat, and then it will form a small nodule or swelling, and then we put it a depot, and then from that depot, you have the drug released slowly over the 6 months period. For a tablet, you're going to take until dissolve. It will get out of your system as soon as possible, because you cannot control how the fat the liver is going to act and so on. So this drug, the best mode of delivery is the injection. Many other formulations are being looked at, like an implant, and then we have other. We are currently working on another study. Still, I'm the national principal investigator. We're working on a study by Merck, where we have one pill that someone takes, and we are testing it for HIV prevention. So that is the longest so far that have been tried. A pill for 1 month, but then you can hardly have a pill for 6 months. So the manufacturer looked at the injection for you are able to have that drug released very slowly over 6 months. And there's also, by the way, one for a year that will be coming soon to Lenacapavir. The results were presented early this year at a conference in Colorado, USA. Yeah.
I have to keep very close to your point, so you have more exciting news coming.
It's coming up, yeah. But for the injection, I know it could be painful, but you look at the risks. What are the benefits and the risks? So should you get infected, or should you just go and be pricked? And it's not that painful, because when we were in Lera, the people that were injected, some of them were interviewed by the media, and they said they were too excited to feel the pain. They didn't even feel the pain. In the clinical trials, we would give a bit of, we'll put some ice, or you put some cream that can cure the pain, or you give them some painkillers. Many of them would say we don't need anymore, but then at least the first few injections. But for here, that they said for them, what they wanted was the injection, just inject now. I don't need anything to cure. I don't feel the pain. Those are the reports. So it depends on your risk perception and the benefit you're getting out of an intervention. But it's exciting to see that we can have and need injection that's given only twice a year currently. And also exciting so that we are getting more options, because I may not want an injection, or I'm not able to take a daily pill, but this pill for 1 month, I can be able to have my pill for 1 month, and then it can take me. And if I have my 12 pills, I can go for a year. But we are still trying his pill. We do not have it available yet. Yeah.
If I may, I pick something. What you said that when you inject me in the fat, it forms me
A dipper?
a dipple. It forms a dipple in the body.
A swelling, a small swelling.
A small cell. So is that small swelling? Is it the one that stay there for 6 months and then keep the rhythm? What does it read?
Oh yeah. So when you're injected, we inject on the upper arm, inject on the abdomen. In the study, we need in the abdomen, and then if we're pregnant, we inject it on the thighs, and now we also inject on the buttocks. So 4 sides: upper arm, abdomen, the thighs, and then the buttocks. So when you're injected, then in the subcutaneous fat, the drug is going to accumulate there, and then it's going to, in that depot, like it's a small nodule or swelling that contains that drug. The drug is in there, and some people can feel it, others you can't feel it, depending on someone's skin. If you're big enough, you do not feel it. If you're very small, you would feel it. And then the drug is going to be released slowly over time from that area. Slowly over time, it's going to get to the different parts of your body, including the reproductive area, the private parts. So by the time you sleep with someone who has HIV, you have that drug in your body, and then the virus cannot enter. You already have the protection from the injection. And that's why we advise people that you keep your schedule, you come on time for injection, because if you come late, that means that the drug levels have gone down and may be protected. So it's very important as we deliver the Lenacapavir to have people remember their dates, or have a system of reminding people to come back for their injections. There's a window, because you know that life is not perfect. Maybe then a day, maybe the 31st of April to come back, but you've traveled out of the country, you also are able, or you lost someone, let me say in the village, and you're not, or you are not well. Any life circumstance may deter you from keeping your appointment. So in the window, you can come 2 weeks earlier than the target date, or 2 weeks after, within 2 weeks. The window of 28 days plus or minus 14 days. Yeah. So but it's very important that you keep within your window so that you can be able to get maximum benefit from this drug. Otherwise, if you miss, then the drug levels go below protective, what we call the protective threshold, and then you can be infected. Yeah.
Yeah, that's what I was going to ask. My day is 1st of May of 2026, and I missed by 1 day. What happens to me? So after those 2 weeks, that 2 weeks window, I still have the drug, but the drug may not be 100%.
Yes, yeah. And some of the infections we saw in the study, when we say that the drug, there were 2 infections, we don't mean that the drug didn't work against the 2 infections, those people. So it means that for some, someone could have come late. If you come late and the drug that should protect you is at this level, and then you come when the drugs are tapering off, going they are below, the drug is there but it cannot protect you. It can even last for a year in the body, but not at a level that can protect you. So we want someone to come in when they are still within that window where they have enough drug in the system to protect them. That's what we need. But the Lenacapavir won't get finished in 6 months. It cannot. It dwindles slowly. But then the level that can protect you, we've researched, and we are confident about the 6 months plus or minus 2 weeks. Yes.
This may sound a stupid statement, but if you inject me like on the arm, let's say I have gotten an accident on this arm, like 2 months after the injection, do I lose my drug and I lose blood? Do I lose my drug, or the drug stays there?
No, the drug stays there. If you lose the blood, the drug stays there. Remember, we said the drug is coming from the injection site. It forms a depot and it's released slowly over time. and it sustains the drug levels to that extent. So you're not going to lose the drug because you have lost the blood. Not at all. Maybe what I forgot to mention is when we are starting someone on Lenacapavir, we give a loading dose. We give you 2 tablets of Lenacapavir, and then those 2 tablets, they are helping the drug levels of the injection to go up quickly, because if you only inject someone without the pill, the loading dose, it may take up to 28 days for the drug to build up, because it builds up over time. But if you give 2 doses, 2 tablets day 1, 2 tablets day 2, and then someone continues on the injection, then they're able to be protected by 48 hours. So 2 days. So we always tell people, I think you saw that article in New Vision, we were telling people to wait for at least 48 hours before having unprotected sex. So at least people should know that you are not protected immediately, that you come to the clinic, you take the 2 tablets, you get the injection, you are given the 2 tablets for the following day, and then you can go and do whatever you want. You wait for end of day 2, and then you can be protected. You can be sure that you're protected.
I hope people and everyone will be patient for those 48 hours.
The thing doing without it, so they should be patient. Use condoms. Use condoms, or be faithful for those 2 days, or abstain. Yeah, but importantly, people should use condoms, and we always emphasize that. We're not telling people to go and engage in risky behaviors because the injection is there. It's like saying that because you have a seatbelt on, you should drive very fast. You should still keep the rules. Then if you have the seatbelt on, I mean, it's protective against fatal accidents. But for this injection, we looked at the trends of the HIV epidemic. We've been having condoms for a long time, and we know that condoms work. Condoms are protective. People who have told us you have an encounter with someone, as soon as you are done, you notice they have this wet happy zesta chisipi. It is still even wet, but then because you used condoms, you test and you're still negative. So people have given testimonies and they're like, the condoms really work. They work if you use them consistently and well. But why do we still see infections happening? Because people are not able to use condoms. Some of them use their condoms and with some partners, and then others, they are not able to maintain the consistency. We have had oral PrEP since 2017 in Uganda, but still we see people are getting infected. So that emphasizes that there is still need for interventions like Lenacapavir, which are not user dependent, whereby you get the injection, then you forget about it. You don't have to remember every day, like for the pill, and you don't have to be embarrassed or have stigma, people to know that you're on this intervention, because you come to a facility, you're injected. Even your spouse may not know that you got that injection if you don't tell them, because it is discreet. It is only you who knows that you got that injection. And I think it's the same reason why for family planning, many women prefer the injection also deeper, because of that discreetness. The partner will not know, the neighbor will not know that they are on family planning. Because if you take like oral pills, you have the structure of the pills there. If you're on maybe the IUD, maybe the partner may feel it. So that discreetness is the secret, and the long time that the drug works. That is the secret, and that's where the strength of this drug is. Yes.
People sometimes ask, is highly effective drug? Does it have some side effects? If they are there, what are they?
Even the oxygen we breathe has side effects. If you took too much oxygen, so everything has a side effect, and good enough for Lenacapavir. The side effects are mainly at the injection site. So when we do the clinical trials, one of the objectives, it's always like even primary, above everything else, above knowing that the drug works, the first thing we need to know is it's safe, because we are dealing with human lives. Is the drug safe? For every clinical trial, that question is the top question. So we did the EASE study, the Purpose 1 and Purpose 2. We collected data. In Purpose 1, there were over 5,000 girls. and then Papa stood over 3,000 men. That's over 8,000 individuals all over the world, and the data are consistent that the injection has almost no side effects apart from the side effects we see at the injection site. Because we have injected you, one, we're going to report the pain. Pain is expected even if you go to a clinic to get an injection for anything else, we'll still get pain. So apart from pain, someone may get redness or changing color because still you've injected them. And then thirdly, what we talked about, the nodules, because the way the drug works, you may inevitably get nodules. Some they're not obvious and some may not report them at all, but some may get other small swellings because the drug is in there, and that's why it's going to come from left at depot and it's going to be released over time. So, and there were minimal, we didn't have any discontinuations actually like Uganda, but someone has discontinued the drug because it's painful. Because of this, no, we did not have anyone withdraw from the study because of side effects, at least not in Uganda.
Okay, that's very good.
So we are assuring the world that this drug is safe. It is safe.
Let's go back to the issue that I've talked about it before. Excitement. People are very excited about this drug. That it can offer 6 months protection. Some people say when we get it, you have freedom to behave the way that you can behave. How are you dealing with the issue of communication? People are excited. What are you telling me?
So we ensured that right from the start, because we have been disseminating these results on radio, on television, meetings, face-to-face meetings, and we've been emphasizing the fact that this drug should not be able to change. You shouldn't be pushed into something because you're taking this, you are expecting to take that drug. So the messaging should be very clear. As health workers give out this drug, even right from the launch, the Minister of Health, Dr. General Achen, in her remarks, she emphasized the ABC and urged people to abstain if you're in school, if you have no partner, abstain. Being faithful for those who are in stable relationships, use condoms if you can be faithful, if you can't abstain. But for those who are not able to fit in those categories, because we said people go through a lot, there's a lot that surround people's lives. There are people who survive on sex. There are people who are not sex workers, but their partners had many other people they are sleeping with, and this young woman needs to be protected. So, and the partner will not accept to use condoms. No, will they allow her to use PrEP because he'll say, you think I'm going to bring you HIV or do you have other partners? So that discreteness. So we are bringing for people who would have otherwise gotten HIV had they not accessed this injection. But we're not saying that for you with your wife because you can be faithful. Now we have this injection, get a girlfriend. No, we're not destroying families. We are not pushing people into risk behaviors. We're not encouraging, and this drug should not cause any disinhibition, but rather protect those who would not have been protected, because why are we still seeing 100 infections per day in Uganda if other interventions work? That means that we came from, by the time we did, I talked about a voice study where women didn't take the oral PrEP, we had about 400 infections, but even 400, 500 infections per day. But then we are saying we are 100. That means that there has been some progress, but the progress is still not to the level that we want, because people shouldn't be getting infected in this day and age. So that's 100 infections per day are the ones we are targeting, the ones we want to prevent, so that 2 years from now, we can say that we have almost no infections and we are eliminating infections by 2030. So we have only like 3 years to go. So this drug and other interventions that are coming, like I talked about the pill, they should be able to bridge that gap and eliminate infections. We have women, when they are pregnant, their partners move out, or when they are breastfeeding, they get other partners, and even a woman who is pregnant and they sleep with someone who is infected, their body is more susceptible to getting HIV than someone who is not pregnant. So pregnant female are prioritized, and if someone is pregnant, they can spread to their infants. So we should make sure that these people access this drug. You're in an unstable relationship, you're not sure of your partner, you are pregnant, you're breastfeeding, you are first on the line. We would want you to get Lenacapavir so that you do not spread to your child. So you can eliminate mother-to-child transmission of HIV. We're still seeing infections in infants. No one talks about this, but we are still seeing children. I'm doing 2 studies here for children who are living with HIV as young as 6 months. 6 months, 1 year, 2 years, and they are there. We actually were given numbers by the sponsor, and we had many more that we had brought, but the slots were taken, meaning that there are many infections that are occurring all over the world and in Uganda. And these infections are happening because we call those mothers of those children in the study, and they're all young women. So it means that the adolescent mothers are the ones who are spreading to their infants. So if we target adolescent mothers and young women not to get HIV, we are also eliminating mother-to-child transmission of HIV.